Alright, welcome to our complete Heme-Onc review for the USMLE. In this video, we're going to have 130 Heme-Onc review questions, tough concepts will be explained, and of course we'll have fun mnemonics along the way. Let's begin with the table of contents. We're going to talk about hemostasis, then anemia, then myeloproliferative diseases, leukemia, lymphoma, and more. So hemostasis, let's begin with question 1. It actually says 701 because this is part of a series. The platelet plug is primarily mediated by von Willebrand factor or tissue factor. We're going to review the platelet plug in a moment, but if you recall, von Willebrand factor controls the platelet plug. Von Willebrand factor you could think of as kind of like the glue which holds together the platelets in the platelet plug by using their GP1B receptors to connect the platelets together. And if you recall, von Willebrand factor is made within endothelial cells, specifically in the Weibel Palade bodies. Desmopressin may be given to a patient to release von Willebrand from their endothelial cells in order to stop bleeding. And if you want just a quick review on primary-secondary hemostasis, here it is. Primary hemostasis is formation of the platelet plug, where again von Willebrand factor acts as the glue. And in secondary hemostasis, that's all about the extrinsic and intrinsic pathways where we form the fibrin clot. And by the way, how is von Willebrand factor involved in this process? It protects factor VIII, and that's exactly why patients with von Willebrand disease may have an elevated PTT, since factor VIII is not being protected by von Willebrand factor. Alright, next question, 702. Which medication primarily activates antithrombin as its mechanism? So of these medications, if you recall, heparin is responsible for activating antithrombin, or unfractionated heparin, which is interesting. Heparin gets so much fame, but it's really antithrombin that's doing all the magic. We take a look at the coagulation cascade, we see that antithrombin 3 is activated by heparin. Once antithrombin 3 is activated, it can then go and inactivate other factors, thereby promoting bleeding. And if you want to just take a look at what the other medications which we listed are used for, warfarin wages war on vitamin K epoxide reductase. TPA aids in conversion of plasminogen to plasmin to break the fibrin, and this is used to break clots in strokes. And you could take a look at these other choices, including apixaban or Eliquis and rivaroxaban, which directly inhibit factor Xa. And one more point, how do you reverse heparin? With protamine. Here's just a little fun mnemonic, the proton that's mean for protamine, smashing the hairpin for heparin. Next question, 703. Aminocaproic acid is the antidote for which toxicity? Of these choices, aminocaproic acid is the antidote for TPA. When TPA is breaking down clots too quickly, aminocaproic acid is the antidote. Aminocaproic, amine to promote clotic. An awful, awful mnemonic that may stick with you. And just as for the other choices, again, heparin is reversed with protamine, FFP for warfarin bleed, but PPC may be required and could work better. Apixaban or rivaroxaban is reversed with andexanet alpha. Next question, PTT is prolonged with normal PT and BT in which of these conditions? And the answer is all of these conditions, because all of these conditions affect the intrinsic pathway. 8, 9, and 11 are all part of the intrinsic pathway, and defects in the intrinsic pathway elevate PTT. As we can see in this picture of osmosis, 8, 9, and 11 are all part of the intrinsic pathway, and therefore hemophilia A, B, and C all lead to an elevated PTT. Let's talk for a minute about how to diagnose. The best initial test is a mixing study. We mix normal plasma with the patient's plasma, and that should correct the PTT because we're providing them with the factors that they need. And the most accurate test is the specific factor assay in order to detect exactly which factor is missing. Treatment, well, there's no cure, but for mild cases we give desmopressin, and in severe bleeding we replace the factor. And in factor 11 deficiency, hemophilia C, we give FFP. Question 705. The most common inherited bleeding disorder is diagnosed either clinically or via the ristocetin cofactor assay. Well, what's the most common inherited bleeding disorder? Von Willebrand disease. And how do we diagnose it? Specifically with the ristocetin cofactor assay. Here I just wrote a little bit about von Willebrand disease. First of all, the types that we need to be aware of are inherited in autosomal dominant fashion. Patients present milder than in hemophilia, but they have prolonged bleeding. And an interesting board's point is that it's worse with aspirin acetylsalicylic acid. Again, here's diagnosis, which we've spoken about already, and treatment, as we mentioned already, is with desmopressin for mild to moderate cases. Factor 7 or von Willebrand factor concentrate can be given for severe or major bleeds, but patients with this condition should definitely be avoiding aspirin and possibly NSAIDs as well. Question 706. Giant platelets are seen in which of these two conditions? In Bernard-Solier syndrome. And we'll have a mnemonic for that in a moment, but just if you recall, both of these disorders present with platelet-type bleeding. For example, nosebleeds and petechiae, with normal platelet counts. The difference is Bernard-Solier has the giant platelets. Here we have Bernard the dog standing by the giant plate to remember that Bernard-Solier involves the giant platelets. Question 707. Which value is decreased in DIC? If you recall, all of these values are elevated in DIC except for platelets. Platelets are being used up all around the body, and therefore platelet count will be low. PT and PTT are elevated because of the consumption of the coagulation factors. And I just have a little bit about DIC presentation over here, which you could take a look at. A board point is that bleeding occurs from venipuncture sites. And treatment, well, of course, we have to address the cause, and we have to transfuse clotting factors and platelets with FFP, and if there's no control, cryoprecipitate may be effective. Let's move on. 708. Coagulation defects, livedo reticularis, obstetric problems, thrombocytopenia, and SLE association, they have antiphospholipid syndrome, clots, fantastic mnemonic. And that's exactly what happens in antiphospholipid syndrome, is that patients get clots. We diagnose this condition with lupus anticoagulant, which I'm going to talk about in a moment, as well as anticardiolipin antibodies or beta-2 glycoprotein. We treat these patients with lifelong heparin or warfarin. If you just want to take a look at what livedo reticularis looks like, here it is. And the reason why I've highlighted lupus anticoagulant over here is that lupus anticoagulant is actually a complete misnomer. First of all, it's not lupus, it's antiphospholipid syndrome. It's true it's associated with lupus. They should call it antiphospholipid anticoagulant. Actually, they shouldn't call it anticoagulant at all. They should call it coagulant, because as we mentioned, in antiphospholipid syndrome, there are clots around the body. There's coagulation. And in fact, lupus anticoagulant is responsible for promoting this coagulation. Something to be aware of. Alright, we mentioned that antiphospholipid syndrome is treated with warfarin. What are the warfarin indications? That is, when is warfarin superior to DOACs? In very limited cases, as we mentioned, of antiphospholipid syndrome, in case of mitral stenosis where a patient has AFib, and in case of metal heart valves. 709. A patient presents with fat RN symptoms. What is the treatment? Fat RN symptoms, fever, anemia, thrombocytopenia, renal dysfunction, and neurologic symptoms. How do we treat the patient? Definitely not platelet transfusion with plasmapheresis. I just wrote a little bit about TTP over here. You recall there's a deficiency of ADAMTS13, which is a von Willebrand factor cleaving enzyme. And if you're not cleaving von Willebrand factor, you're going to end up with very long von Willebrand factor multimers, which causes microthrombi, shearing the red blood vessels, and leading to end organ damage. But in terms of treatment, as we mentioned, plasmapheresis, steroids can actually help in TTP. Since it's antibody-mediated, this is unlike TTP's sister, hemolytic uremic syndrome. Caplacizumab is a medication which works just like ADAMTS13, antibody against von Willebrand factor. And therefore, giving this medication kind of works as a replacement for ADAMTS13. Here's a little mnemonic that I had. Capital city man for caplacizumab, total poo for TTP. And rituximab and orelizumab are anti-CD20 drugs that stop production of antibodies to ADAMTS13, which may be used. 710. What is seen in hemolytic uremic syndrome but not in TTP? Well, schistocytes are seen in both conditions. Neurologic dysfunction, that's only seen in TTP. The answer is a preceding E. coli hemorrhagic diarrhea. Just a word about treatment for HUS. Most resolve on their own, but eculizumab may help. You can consider dialysis and plasmapheresis in severe cases, but remember that steroids do not help in hemolytic uremic syndrome because it's not antibody-mediated. 711. A condition in which IgG autoantibodies are formed against one's platelets, and the platelet antibody complex is destroyed by the spleen. That's the condition of ITP. How is that diagnosed? Diagnosis of exclusion. ITP stands for I tear platelets. That is the spleen talking here. The spleen tears the platelets. The spleen then tears the platelet antibody complex. Alright, now let's talk about anemia. So anemia is when there's decreased red blood cell mass, i.e. hemoglobin, in the blood, because red blood cells hold the hemoglobin. Symptoms for all anemias can be identical. That is, patients have fatigue, pallor, and other symptoms, so no diagnosis can be made from symptoms. We have to look at the lab values. The best initial test for anemia is CBC to establish the presence of anemia, and the first clue to etiology is the MCV. So if you have a CBC, the first thing you want to look at in cases of anemia is the MCV. Right, so here's our question. Ferritin levels in iron deficiency are increased or decreased, and ferritin levels are decreased in iron deficiency, and this is very specific for iron deficiency, low ferritin levels. This is how we contrast iron deficiency and anemia of chronic disease. I just wrote causes of microcytic anemia over here. Iron last, 5 causes of microcytic anemia. But our question is going to be, which of these microcytic anemias can show hypochromic cells and target cells? Here we see the target cells, and the answer is we can really see it in all of them. And that's why we don't use peripheral smear in a diagnosis of someone with microcytic anemia, because all of them can show these cells. 713. What's the most common cause of anemia presented by the Prussian blue stain shown? So this is sideroblastic anemia, where we see the iron piling up in the mitochondria surrounding the cell. We see this most commonly in alcohol. Alcohol can cause a sideroblastic anemia. Actually, all of these can cause sideroblastic anemia, but alcohol is the most common cause. Now, I wrote a note over here that sideroblastic anemia is the only form of microcytic anemia in which serum iron level is elevated. Question 714. 2 genes deleted in which condition is really bad, alpha or beta? So beta is 2, so beta 2 is really bad. If we recall alpha thalassemia and beta thalassemia, I just wrote a note over here that in beta thalassemia major, where 2 genes are defective, patients often die by the age of 30. And since they're getting these chronic transfusions, they have to get iron chelators. A man has fatigue, pallor, and decreased sensation in his feet. Hematocrit is 27%, and MCV is 115, so it's high. What is the next step? We want to get a peripheral blood smear, and this is to see if there are hypersegmented neutrophils in order to distinguish between macrocytic anemia, regular macrocytic, and megaloblastic, where we see the hypersegmented neutrophils. Then we can narrow it down to folate deficiency or vitamin B12 deficiency, and after that, we could do further workup. For example, with a vitamin B12 or a folate level. 716. What's the most common neurologic abnormality in vitamin B12 deficiency? And the answer is peripheral neuropathy. Subacute combined degeneration is classic, but not as common, and dementia is even less common. 717. A patient presents with fatigue, pallor, chylosis, diarrhea, loss of appetite, and now has irritability and psychosis. CBC shows a low hemoglobin and a high MCV. What will the methylmalonic acid levels be? So as you mentioned, in case where there's neurologic deficits, vitamin B12 deficiency, methylmalonic acid levels will be elevated. We normally don't see neurologic symptoms in folate deficiency. I just wrote a note over here that normal MCV is between 80 and 100, and therefore, for example, if a patient had 72, that would be considered extremely low. All right, before the next question, let's just introduce hemolytic anemia. So all forms of hemolysis can lead to decrease in hematocrit, increased LDH, bilirubin, and reticulocytes, and slight increase in MCV because the reticulocytes are larger than red blood cells, and folate deficiency from the increased turnover. With this introduction, let's begin the next question. A black male patient presents with fatigue, dark urine, and shortness of breath after taking TMP/SMX for a cold. What's the best initial test? So this sounds like G6PD deficiency. We want to look at the smear, the CCB and the smear. The smear is going to tell us whether or not we see the bite cells and the Heinz bodies. The most accurate test is actually a G6PD level 1 to 2 months after an episode, because right away the levels will be normal. That's why I wanted to check it 1 to 2 months later, and this is the most accurate test. And on the bottom, you can take a look at various triggers for this condition, and the most common is actually infections, more than fava beans, more than isoniazid, and more than TMP/SMX. Question 719. Flow cytometry shows absence of decay accelerating factors, so this is PNH, paroxysmal nocturnal hemoglobinuria. The best initial treatment is prednisone. Remember, in this condition, the CD55 and 59 molecules found in red blood cell surfaces cannot attach because their anchoring molecules are deficient, leading to anemia, and also leads to thrombosis, especially in the mesenteric and hepatic areas. Treatment is initially with prednisone. We can give eculizumab in order to inhibit complement, and the only real cure is bone marrow transplant. 720. A patient presents with extravascular hemolysis anemia with splenomegaly and jaundice. So this is spherocytosis. What is the most accurate test? This is a new one. This is actually eosin 5 myeloid flow cytometry. It used to be the osmotic fragility test, but now it's eosin 5 myeloid flow cytometry. Just keep that in mind for exams. About hereditary spherocytosis over here, and I wrote the symptoms include recurrent hemolysis, intermittent jaundice, splenomegaly, and bilirubin gallstones. We may need to manage it with splenectomy to stop the hemolysis, but again, it doesn't get rid of the spherocytes. 721. A child with anemia and jaundice has bilateral hand and foot swelling. So this sounds like sickle cell. What's the most accurate test? The hemoglobin electrophoresis is the most accurate test for sickle cell anemia, not the smear, even though we see the sickled red blood cells. Here is have a picture of the swelling, the dactylitis. You can take a look a little bit about sickle cell anemia over here, the pathophysiology that valine replaces glutamine on the beta glucose chain, resulting in HBS rather than HBA. Let us move on. 722. What can be found in the blood smear in sickle cell patients? So we find jowly bodies because the spleen is gone, autosplenectomy, and therefore the spleen will not be taking away these defective red blood cells. And in terms of the other choices, basophysic stippling is associated with sideroblastic anemia, for example in lead poisoning. Well, especially lead poisoning. Morula is seen in the microcolonies of anaplasma and neuralgia in the white blood cells. 24. What's the cause of aplastic anemia in sickle cell patients? This is parvovirus B19. And the most accurate test for parvovirus B19 is PCR for DNA. It's better than an IgM level. And the treatment for parvovirus IVIG is the initial treatment, and if we need to, we give a blood transfusion. And remember that parvovirus destroys reticulocytes, which is terrible in sickle cell patients because they normally have and need to have high reticulocyte counts because of their sickled red blood cells. That's why parvovirus B19 is especially bad for sickle cell patients. 725. Autoimmune hemolytic anemia is similar to hereditary steatosis in that both, while there may be spherocytes, direct COMLEX is only going to be positive in autoimmune hemolytic anemia. That's one of the ways we differentiate the two. And here's a little bit about autoimmune hemolytic anemia. Warm versus cold. Remember, warm is the IgG one. It's associated with SLE, CLL, lymphoma, penicillin, rifampin, and phenytoin. The most accurate test is the COMLEX test. And the cold agglutinin disease, that's associated with IgM, mycoplasma, EBV, and Waldenstrom macroglobulinemia, all the M's. IgM with the M's. The most accurate test is the cold agglutinin titer. 726. Sometime after developing mycoplasma infection, a man has numbness, pain, and purple discoloration of the skin. Warming improves it. This sounds like cold agglutinin. What is the treatment of the severe form of this disease? So the severe form is not treated with splenectomy. It's treated with rituximab, cyclophosphamide, and plasmapheresis. Only warm hemolytic anemia can potentially be salvaged with splenectomy, as opposed to the cold one. The steroids and splenectomy are not effective. Okay, so now we're going to talk about myeloproliferative disorders. So myeloproliferative disorders are blood cancers caused by changes in stem cells inside the bone marrow. And these changes cause the body to make too many blood cells, either white, red, or platelets. For example, essential thrombocytosis, there are too many platelets, hypereosinophilic syndrome, there are too many eosinophils, and polycythemia vera, too much of all three cell lines, but primarily red blood cell production. All right, so 727. Splenomegaly, headache, fatigue, and thrombosis, pruritus after showers. So what is this condition over here? Where there's going to be pruritus after showers? Well, one of them is polycythemia vera, and that's exactly what's going on over here. Again, polycythemia vera is an increase in all three cell lines, but especially red blood cells. The pruritus comes from the fact that there's a histamine release, as heat causes mast cells to release histamine. So the heat, it's not the water of the shower, it's the heat of the shower. Histamine is released, and this is because the reason why they get itchy is because there are so many basophils, so many mast cells in these patients, so they get itchy. The most accurate test is the JAK2 mutation. We see this in 95% of patients. And its diagnostic tests also include markedly elevated hematocrit, elevated platelets and white blood cells, and elevated total red blood cell mass. Iron is actually going to be reduced. And the treatment is phlebotomy. Also, aspirin. 727. Splenomegaly, headache, fatigue, thrombosis, and pruritus after showers. So what's this diagnosis? This is polycythemia vera, again, where we see an increase in all three cell lines, especially red blood cells. Now there's going to be itching because of the histamine release, because these patients have so many basophils, so many mast cells, so there's going to be histamine release from the heat of the shower. It's not the water, it's the heat. And the most accurate test is the JAK2 mutation. We see this in 95% of patients. All right, and other lab values you see over here, but there's actually going to be a reduced iron despite the elevated red blood cell mass. Treatment is phlebotomy and also aspirin to prevent thrombosis. The target hematocrit is less than 45%. That's what we want phlebotomy to get to, and hydroxyurea is given to lower the cell count, if not ruxolitinib. Question 728. A person with polycythemia vera has occlusion of the hepatic vein causing potentially fulminant liver failure. So this is Budd-Chiari syndrome. That's the answer over here. And we diagnose with imaging. I wrote imagine. We diagnose with imaging and we treat it with a shunt placement. We do a shunt specifically to shunt the blood away from the obstructed vein to another. 729. A 50-year-old man with no complaints is found to have a platelet count of 1.2 million and is diagnosed with essential thrombocytosis. So what's the treatment? So actually when it's 1.2 million, it's fine as long as the patient is asymptomatic. They have 1.2 million, it's not a problem. Indications for treatment include older than 60, platelets are more than 1.5 million, and thrombosis develop. So we give hydroxyurea to patients with this condition. 730. A patient with a history of eczema, urticaria, cough, and shortness of breath has eosinophil count more than 1,500. Negative ANA, no cancer infection is found. What's the diagnosis? I already gave it away. Hypereosinophilic syndrome. What's the treatment? We give steroids in order to suppress the production of the eosinophils. All right, now let's talk about myeloma. So myeloma is abnormal proliferation of plasma cells. Multiple myeloma, 731. Most common symptom is bone pain from pathologic fractures. An osteoclast activating factor attacks bone, leading to the lytic lesions. And CRAB stands for calcemia, hypercalcemia, renal failure, lots of causes to the renal failure, anemia due to plasma infiltration of the marrow, and bone lesions, the lytic lesions. And the smear shows the rouleau formation, where we see the IgG paraprotein stick to red blood cells, causing them to stick to each other, and they look like poker chips. 732. What's the most accurate test for multiple myeloma? The most accurate test is bone marrow biopsy. The M spike is totally incorrect. don't choose it on the exam day because 99% of those with an M spike don't have myeloma, they have MGUS. Bone marrow biopsy shows more than 10% plasma cells, which is very, very, very specific for multiple myeloma. 734, a patient has lethargy, blurry vision, and mucosal bleeding. Serum protein electrophoresis shows an M band. So this is Waldenstrom microglobulinemia. What's the treatment? So for these patients, we give plasmapheresis. It's the best initial therapy to remove the IgM, which is causing the viscosity. So the plasmapheresis reduces the viscosity. You can take a look at the other treatments over here. All right, introduction to leukemia. So we have leukemia, which is cancer that starts in the bone marrow, and there are various types: acute leukemia, chronic leukemia, and hairy cell leukemia. Let us begin. Actually, over here, we see the lineages of the myeloid lineage and the lymphoid lineage. You can take a look over here. All right, 735. What's the best initial test for acute leukemia? So here we want to get a blood smear that shows blasts. And after that, and here we can see the different blasts. We see ALL shows blasts, and AML also shows blasts, and also shows the aurads. I wrote a note over here that there's more cytoplasm seen in AML, and here you can see a bigger picture of the aurads, those little lines over there. Okay, all high-yield stuff for acute leukemia I'm going to write over here. Symptoms include signs of pancytopenia. The best initial test is blood smear. Flow cytometry is most accurate. Treatment of AML and ALL is chemo to remove the blasts. You may need bone marrow transplant if there's a poor prognosis. In patients with M3, which is promyelocytic leukemia, it's associated with a 1517 translocation, add ATRA. For some reason, this condition is responsive to ATRA and or arsenic trioxide, which people are less familiar with, but it's an alternative. ATO, ATRA or ATO, and aurads myeloproliferative is seen in AML. We inject chemo, specifically methotrexate, into the spine in ALL patients because ALL recurs in the spine and the testicles. 735, who's responsible for the smudge cells seen in CLL? Is the antibodies or the scientist? The answer is the scientist. The scientist puts the glass on the specimen to check it under the microscope, and then actually, since these cells are so fragile, they get destroyed or smudged, and that's how they form. All right, all high-yield stuff about CLL. The median age of 65 occurs more in males. The presentation, patients are often asymptomatic, but they may be fatigue, lymphadenopathy, splenomegaly. The best initial test, of course, is the smear, most accurate flow cytometry. And the flow cytometry shows the CD5 markers on B cells. And in staging, so 0 to 2, there's no treatment. 0 to 2, well, in 0, there may be elevated white blood cells. In 1, there's lymphadenopathy. And in 2, there's hepatosplenomegaly. Treatment, so is only in stage 3, and that's, for example, anemia develops, there's recurrent infections, and these are the medications that we give them. For example, fludarabine, I like to think in CLL, for you is Dr. Bean. Fludarabine, for you is Dr. Bean in CLL. Fludarabine is used in CLL. 737, what's most accurate test for CML? Chromosome analysis for Philadelphia chromosome showing P922 translocation. What's the treatment? Tyrosine kinase inhibitors, imatinib, dasatinib, nilotinib, and BMT is curative, but not done initially. We'd rather go with the tyrosine kinase inhibitors because we're able to use them. 738, which of the following is associated with CML? And the answer is all of these. Pruritus after showers, splenomegaly, fatigue, night sweats, elevated basophils and neutrophils, small number of blasts, and LEP score down, opposed to in leukemoid reaction. Now, which is we remind ourselves of the lineage in CML, it affects the myeloid progenitor pathway, and that's what's going to be affected. And that's why patients have the pruritus after showers, just like in polycythemia vera, because the elevated basophils, they release the histamine. Splenomegaly presents with early satiety and left upper quadrant pain. 739, a cancer that presents similar to CLL, with a blood smear showing hair-like cytoplasmic projections, that is going to be hairy cell leukemia, and we treat them with cladribine or pentostatin. All right, now to talk about lymphomas. These are malignant transformations of lymphoid cells residing primarily in lymphoid tissues, especially the lymph nodes, and there are two main types, Hodgkin and non-Hodgkin lymphoma. All right, here's a little bit of difference about the two. So Hodgkin lymphoma is localized mainly in the neck, and non-Hodgkin lymphoma is disseminated. We see nodes all over the place. Hodgkin lymphoma presents with the Reed-Sternberg cells, the distinct CD15 positive and CD30 positive B cells, whereas non-Hodgkin lymphoma is mainly B cells, sometimes T cells, but we don't see these Reed-Sternberg cells. In Hodgkin lymphoma, there's an EBV association, and in non-Hodgkin lymphoma, there's an HIV and autoimmune association. Let's talk about this condition. Painless waxing and waning adenopathy is seen in follicular lymphoma. Starry sky appearance biopsy, jaw lesion in Africa, abdominal lesion in Americas, associated with EBV. What is the translocation? The Burkitt lymphoma, where we see a T814 translocation. 742, T-cell lymphoma in the skin with cutaneous eczema-like lesions, and pruritus. This is mycosis fungoides. Sometimes really does not look pretty. 743, what type of biopsy is done in lymphoma? So we use excisional lymph node biopsy. We don't use needles on nodes, even though we would like to, but we don't want to pop those nodes with needles. We use excisional lymph node biopsy. 744, the most common Hodgkin lymphoma chemotherapy is ABVD. Adriamycin, which is doxorubicin, bleomycin, vinblastine, and dacarbazine. ABVD. What does radiation in Hodgkin lymphoma increase the risk for? Solid tumors, breast, thyroid, lung, and premature coronary disease. 746. Which chemotherapy medication leads to irreversible cardiotoxicity? This is doxorubicin because trastuzumab is actually reversible. And in terms of the other ones, you could take a look over here at their adverse effects. Vincristine is neuropathy, bleomycin lung fibrosis, and you could take a look at the other ones. And cyclophosphamide, we prevent the hemorrhagic cystitis with Mesna. Random questions, and of course in this condition we'll see some repetition. That's okay. Repetition is good when it comes to studying. Let's take a look. Question 747, this is new stuff. Cafe au lait spots, short stature, radial or thumboplasia is seen in which condition? This is Fanconi anemia, where we see this thumboplasia. As opposed to diamond black fan anemia, we see a triphalangeal thumb. And these other things over here. You could take a look. So you could take a look at Fanconi anemia over here, where we see the thumboplasia. And on top in the picture over there, we see diamond black fan anemia. 748, a 30-year-old man from Greece comes in complaining of chronic fatigue. Hemoglobin is 10.4, MCV is 71. He's put on oral iron for a month, but no improvement. What's most likely diagnosis? So this is thalassemia, where again we see patients often from the Mediterranean, microcytic anemia, and no response to iron. That's most likely beta thalassemia. The most common childhood malignancy is ALL, is most common childhood malignancy. Here's a little bit of AML and ALL, and the diagnosis based on presentation. You can take a look at the age over here. ALL shows up in kids, AML in younger to middle-aged adults, CML older, and CLL even older. 750, what's the preferred therapy in APL? I guess we said before, ATRA. Right, you can take a look over here. 751, lymph nodes suspicious of malignancy are generally small. Sorry, I was thinking benign. Malignancy ones are generally big. They're fixed and firm, as opposed to ones that are benign are mobile, and they're often bilateral. All right, infections cause, viral ones are non-tender, bacterial ones are often tender. 752. So we saw this already. Hypercalcemia, renal involvement, anemia, bone lesions are seen in multiple myeloma. You can take a look at that over here. Most of this is just review. 753, B-cell malignancy associated with EBV. What's the best initial test? We spoke about this already. This is excisional lymph node biopsy. That's what we do in cases of lymphoma. We get excisional lymph node biopsy. Here we're talking about the Hodgkin lymphoma association with EBV. 753, did I do this again? 753. I should have said 754, I think. All right, a clonal disorder of B cells leads to malignant monoglomerulopathy, increased level IgM, and hyperviscosity. So this we spoke about already. Hypercellular bone marrow cells and the Dutcher bodies. Actually, I didn't mention the Dutcher bodies, but that's what we see in Waldenström macroglobulinemia, where the IgM leads to the hyperviscosity, and we get rid of that possibly with plasmapheresis. Question 754, once again, we have another 754. Neutropenia is defined as absolute neutrophil count less than 1,500. Normal neutrophil count should be between 2,500 and 7,000, and absolute neutrophil count less than 1,500 is neutropenia. You could take a look at neutropenia on the side over here. In the chronic form, patients present with sinusitis, stomatitis, gingivitis, and perirectal infections and treatment. You could take a look over here. One of the things that we want to talk about, besides antibiotics, is GCSF to help shorten the duration of the neutropenia. Question 755, eosinophilia, where the eosinophil count is elevated, is most commonly caused by allergies. Allergies is the most common cause. All these can cause eosinophilia. NAACP, was I trying to make a mnemonic out of that? I don't remember, but all of these can cause eosinophilia, and you can take a look a little bit up there on top. All right, parasites, one of them would include schistosomiasis. We look for the hematuria. 756, diagnosis of Hodgkin lymphoma is with, as we mentioned before, it's with lymph node biopsy, not a needle biopsy. We do excisional biopsy. 757, a teenage boy has an anterior mediastinal mass along with pancytopenia and hepatomegaly, as well as superior vena cava syndrome and cough. So if a teenage boy has an anterior mediastinal mass, it's likely a lymphoma. Which one shows up in kids? Well, that's ALL, and that affects the left testicle. Well, it affects the testicles. 757, once again, which value is seen in hemolytic uremic syndrome? We see a decreased platelet count. PT will not be elevated, and serum haptoglobin will be decreased. And as we mentioned before, hemolytic uremic syndrome is common after infection due to Shiga toxin producing E. coli. 758, a 60-year-old patient has an incidental finding in large mediastinal lymph nodes. The patient has no symptoms and the nodes are non-tender. What's the cause? This is due to gene overexpression. This is follicular lymphoma, which we spoke about before. 759, children with immune thrombocytopenia petechia require, as we mentioned before, observation at first because they have no symptoms. Splenectomy is only when it's severe and they don't have any, there's no other choice. All right, Again, in case of bleeding with no response to steroids and IVIG. 760, a high leukocyte alkaline phosphatase level is seen in leukemoid reaction. We said before, the LAP is high leukemoid reaction versus CML. Okay, 761, which is seen in hairy cell leukemia, we said splenomegaly. 762, a patient with long-standing SLE has low-grade fevers, fatigue, weight loss, and lymphadenopathy. So in weight, we don't really see weight loss with SLE so much. We see that more with malignancy. There are no joint symptoms, so it's unlikely a flare. Rash, ulcers, or serositis. What is the most likely diagnosis? Non-Hodgkin lymphoma. It's more a non-Hodgkin lymphoma and not a flare. Question 763, a 66-year-old man has generalized lymphadenopathy, splenomegaly, and fatigue. What's the cause of his anemia? So here we have CLL. In all these diseases, the myeloproliferative diseases, there's bone marrow infiltration, and that's what prevents the red blood cells from being produced properly. That's what we see over here. 764, an 18-year-old girl has nosebleeds and heavy menses. Hematocrit is 35%, platelets are 9,000, leukocytes are 5,500, spleen is non-palpable. What's the cause? So here it's due to a production of platelet autoantibody. This is ITP, immune thrombocytopenia. And it's not von Willebrand disease, even though the presentation seems like it. And that's because the platelet count would be normal in that condition. Over here it's 9,000, which is extremely low. 765, a 4-year-old boy has fatigue, easy bruising, non-tendon lymphadenopathy, hepatosplenomegaly. He had a surgical procedure last year with no complications. That's unlikely deficient factor VIII production. This is most likely a deficient platelet production due to a condition ALL. It crowds out, and therefore the deficient platelet production, that's what leads to bleeding. 66, a lethargic newborn on phototherapy has rising bilirubin levels. That's not good. For these patients, we want to get exchange transfusion therapy. That's an indication in these neonates. Question 767, a 6-hour-old infant born to a mother who had preeclampsia with severe features has respiratory distress with a hematocrit of 71%. So this is a polycythemia. Auscultation reveals normal heart sounds. What's the treatment? So it's not cardiac surgery because the heart sounds are normal. We want to give fluids and glucose in this polycythemia. All right. 768, a newborn with fatigue is evaluated. Electrophoresis shows 5% hemoglobin A2 and 90% hemoglobin F. In addition to chronic transfusions, the patient will require chelation therapy because of the chronic transfusions in order to get rid of the extra iron. All right. 769, an 18-month-old has itchy, red, scaly skin, microthrombocytopenia, and recurrent infections. He has a defect in his cytoskeleton regulation because this is without Aldrich syndrome, which is an X-linked disorder characterized by a triad of thrombocytopenia, eczema, and recurrent infections, and there's a defect in the cytoskeleton regulation. That's what's going on over here. 770, a baby has jaundice, hemolytic anemia, and elevated MCHC. So elevated MCHC is basically pathognomonic for hereditary steatosis because we don't see that in the other anemias. 771, microcytic anemia and normal red distribution width is seen in thalassemia minor. In iron deficiency, we see a high red distribution width because of the range of sizes of the red blood cells as the new ones are being produced. 772, in splenic sequestration crisis in sickle cell disease, what will be seen? We're going to see high reticulocytes and low platelets as the red blood cells are killed by the spleen. This occurs in patients who have not been autosplenectomed yet from vaso-occlusion and infarctions. We give these patients fluids, transfusions, and eventually splenectomy. 773, a 10-year-old unvaccinated boy is brought to the ED with high fever, poor appetite, irritability, and then dies. Oops, I gave it away already. Conjugate capsular polysaccharide vaccine. He should have gotten this. Well, we're going to see further in the question that he had been hospitalized several times before for abdominal pain and history of bloody urine, which sounds like sickle cell disease. That's why the reticulocyte count is high. So the pneumococcal vaccine could have prevented his death. Again, sickle cell patients should get this because of the splenectomy. 2 times daily prophylactic penicillin should be given until age 5 in these patients. So again, until age 5, they're not going to get the vaccine yet, and therefore they should get prophylactic penicillin. Question 774. A boy from the Mediterranean presents with fatigue and pallor. Sounds like thalassemia, but it's actually not. His diet mainly consists of dairy products such as ice cream and milk. Hemoglobin's 8. MCV is 70. Okay, so it's either iron deficiency or it's thalassemia. Erythrocytes 3 million. So that's what really gives it away because the erythrocyte count in thalassemia would be normal or elevated. This is a low erythrocyte count. So this is more likely iron deficiency, and it's probably because of his diet. He's not getting any meats. 775, which drugs can safely be given in G6PD deficiency? And the answer is cephalosporins. These others cannot, as we spoke about before. Okay. Penicillin class medications such as amoxicillin and cephalosporins are safe to use in patients with this condition. 776, a 16-month-old boy has splenomegaly and left-sided abdominal tenderness along with fatigue, pallor, and a flow murmur. What is the culprit? So over here, this is valine. This is sickle cell anemia. That's why he has these symptoms over here. The symptoms suggest an acute splenic sequestration crisis, a life-threatening complication of sickle cell disease. The sickled red blood cells become trapped in the spleen, and it gets bigger, resulting in pallor and fatigue. Question 777, the treatment for ischemic stroke stroke in sickle cell patients, for example, a 14-year-old girl, a girl with a stroke, we want to give exchange transfusion because it replaces the sickle red blood cells and improves the viscosity. It limits the occlusion, causing the stroke. 778, an acute drop in hemoglobin to severe anemia, 4.5, along with a low reticulocyte count in sickle cell disease is due at 2, we mentioned this before, aplastic crisis due to parvovirus, not aplastic anemia. That's congenital. That would be, for example, in Fanconi anemia or something like that. Other causes of aplastic anemia. 779, the medication for sickle cell anemia that causes myelosuppression also causes macrocytosis. That is hydroxyurea. Hydroxyurea causes macrocytosis and myelosuppression due to inhibition of ribonucleotide reductase. And as we mentioned, hydroxyurea increases HbF levels. 780, a 5-year-old boy at 5th percentile of her height has easy bleeding, bruising, and anemia. MCV is high, and the thumb is hypoplastic with flattened thenar eminences. What is the cause of this condition? We spoke about this before. Defect in DNA repair. Fanconi anemia, where they have the thumb is going to be small. Treatment is with stem cell transplant. 781 was the cause of the abnormality in the image shown. So this is a red blood cell precursor remnant. We said the spleen is not eating it up. Howell Jolly bodies. 782, a 51-year-old man has new onset hypoxia by pulse ox, 83%, but the oxat on blood gas is 99. This is methemoglobinemia, oxidation of iron. That's what causes acquired methemoglobinemia, oxidation of iron in hemoglobin, and the pulse ox is going to show something low, like 85%, but the oxat is going to be 99% due to blood gas because there is dissolved oxygen in this condition. 783, Coombs negative hemolytic anemia, jaundice, and splenomegaly. The best test is, we mentioned this, EOSIN 5 myeloid binding test, the flow cytometry for spherocytosis. All right, 784, an asymptomatic 2-month-old baby is incidentally found to have normocytic anemia. So it is 10.1 grams per deciliter. What is the cause? So this is reduced red blood cell production. It is physiologic anemia in infancy, which resolves after 3 months. All right. 785, a 42-year-old man with erectile dysfunction is brown skin pigmentation, mostly over the face and both arms. Liver enzymes are slightly elevated. This is iron overload, hemochromatosis. He's at risk for hepatocellular carcinoma, seen in 50% of patients with iron overload with hemochromatosis. By the way, what's the most common cause of death in hemochromatosis? It's liver disease. That's how these patients die. 786, the workup of a suspicious breast mass is the same in men as women. That we go with mammography and then biopsy, and this is definitely true. All right, mammography is done for men as well. 787, an 18-month-old baby has a palpable abdominal mass, weight loss, fever, and periorbital ecchymosis. So if you have a little baby with an abdominal mass, you need to think of neuroblastoma, and that also explains that periorbital ecchymosis and opsoclonus myoclonus is a rare condition seen in some cases. 788, tumor lysis syndrome, which value is decreased, calcium decreased in tumor lysis syndrome. Potassium and phosphate will be elevated. You could take a look at tumor lysis syndrome over here. Treatment includes fluids and resveratrol to prevent the uric acid buildup, continuous telemetry, and aggressive electrolyte monitoring and treatment. 79, 56-year-old woman presents with mild hypercalcemia in the setting of a metastatic breast cancer to bone. What should be given? We give bisphosphonates to these patients. Bisphosphonates are first line for stabilizing bony metastatic lesions to prevent hypercalcemia malignancy and pathologic fractures. Loop diuretics, in contrast, are given to patients with moderate or severe hypocalcemia with volume overload from heart failure or renal insufficiency. 790, tumor lysis syndrome. Prophylaxis is fluids. We want to give fluids to wash everything out, prevent the acute kidney injury, prevent uric acid elevation with allopurinol and resveratrol. 791, a 54-year-old smoker has face and arm swelling along with unintentional weight loss. The veins on the anterior chest wall are engorged. Next step, we want to get a chest x-ray for superior vena cava syndrome. The most common cause is malignancy such as lung cancer or NHL. And it leads to this venous congestion. Okay. 792, a 20-year-old man has progressive shortness of breath and cough. CT of the neck shows a large anterior mediastinal mass causing tracheal compression. So this is a cancer. AFP and B HCG are elevated. What's most likely diagnosis? This is most likely a mixed germ cell tumor. Anterior mediastinal mass includes the 4 T's: thymoma, teratoma, germ cell tumors, and terrible lymphoma, and thyroid neoplasm. So if the AFP and beta HCG are elevated, it's likely a malignant germ cell tumor. 93, what's the first line treatment for chemo-induced nausea? So we give Zofran, ondansetron, serotonin receptor antagonists. They have a low side effect profile and are highly efficacious. Anticholinergics such as scopolamine is for motion sickness. Dopamine antagonists such as metoclopramide is not first line. And modulin receptor agonists such as erythromycin for gastroparesis. 794, what does the PET scan of a patient with Hodgkin lymphoma demonstrate? Why does it demonstrate high tracer uptake in the brain, kidney, and liver? And that's simply because of healthy glucose requirement in those areas. You can take a look at that over here. Now, when we give the PET scan, we see high tracer uptake in those areas because they're highly, they take up the glucose because they have a high requirement. 795, a 13-year-old girl was feeling well until a few months ago when she started feeling fatigue. She has a few brown macules on her lips and buccal mucosa. What's the next step? We want to get an upper and lower endoscopy because this is Jager's syndrome, I think that's how you pronounce it. It's autosomal dominant. It has this iron deficiency anemia, the microcytic anemia, and you need the upper and lower endoscopies to look for polyps. 796, for the first 8 years after Hodgkin lymphoma cure, most deaths are due to HL relapse, Hodgkin lymphoma relapse. In the first 8 years, it's Hodgkin lymphoma relapse, and after that, the deaths are due to secondary malignancy. 797, mediastinal mass causing chest discomfort and non-specific respiratory syndrome. This is a bronchogenic cyst. I wrote that over here. The mediastinal masses are the bronchogenic cysts and the esophageal carcinoma. All right, that's from my mnemonic for my YouTube channel. So again, this is the bronchogenic cyst. 798, a woman with early rheumatoid arthritis has moderate anemia with low serum iron and low TIBC. So this is definitely not iron deficiency. What step will improve her anemia? So we give them MTX or hydroxychloroquine. That helps the anemia because this is anemia of chronic disease where there's low serum iron and low TIBC. We treat the underlying condition. 799, a patient took amoxicillin and developed anemia with fatigue, splenomegaly, and jaundice. What's the next step? So this sounds like drug-induced hemolytic anemia. So you want to stop the amoxicillin. It's interesting. Drug-induced hemolytic anemia can be caused by penicillin and cephalosporins. These are the two drugs which I mentioned before, are two drugs which do not cause G6PD deficiency flares. So this is due to penicillin and cephalosporin. What happens is they bind to the surface of our blood cells, creating a hapten for IgG attachment, and that's what leads to extravascular hemolysis as the IgG-coated erythrocytes are swallowed by the splenic macrophages. Question 800, in polycythemia vera, EPO levels are going to be high or low? I wouldn't have asked if it was high. Low. What happens is that the JAK2 takes over the system, not the EPO. EPO tends to be low. Symptoms include, as I mentioned before, aquagenic pruritus, facial plethora, and splenomegaly. 801, transplantation from one identical twin to another is syngeneic. Allogenic is from donor to another. Autologous is person to self. 802, which condition is most associated with lymphomas? H. pylori, malt lymphoma. You can take a look at these conditions and their associations. Question 803, the 63-year-old smoker. CBC is normal, P is otherwise normal, so it's unlikely lymphoma. Squamous cell carcinoma, that's often how it presents. This is most common malignancy is an upper cervical node is head and neck squamous cell carcinoma in this smoker. 804, 3-year-old girl has a sudden onset weakness, hypotonia, hyperreflexia in the right arm and leg. She has no fever. What study is most appropriate? So this sounds like a stroke. So we want to get hemoglobin electrophoresis because that can cause stroke in sickle cell patients. All right, you can take a look at these other choices. 805, epidermal spinal cord compression producing back pain and bladder dysfunction in a patient with history of malignancy. We need to get steroids even before we image with an MRI because it is so incredibly dangerous. 806, a 65-year-old woman has 6 months of progressive fatigue and anorexia. In situ hybridization shows an abnormality in chromosome 22. So she has fatigue and anorexia. Sounds like a malignancy. Which malignancy affects 22? That's the Philadelphia chromosome tyrosine kinase. We want to target that. This is chronic myelogenous leukemia, the Philadelphia chromosome, BCR-ABL fusion. 807, a person recently diagnosed with DVT on warfarin now has worsening pain and swelling in the right leg, INR is 3. We see a popliteal venous thrombosis. What's the next step? We want to replace warfarin with rivaroxaban. As we mentioned, warfarin should only be used in metal valves, antiphospholipid antibody syndrome, and in case of mitral stenosis with a fib. Here, there's a problem using warfarin. We want to replace it with rivaroxaban. It doesn't increase the risk of bleeding complications, a rapid onset of action, and no requirement for INR monitoring. We prefer these DOACs. 808, a 44-year-old man has headache and confusion. Platelets is 43,000, really low. BUN is 30. Hemoglobin is 8.4. Blood smear shows fragmented red blood cells. What's the next step? We want to get plasma exchange because it sounds like TTP. That's why we have the low platelets, the head symptoms, the CNS symptoms, the anemia, and the schistocytes, the fragmented red blood cells. 809, a person has this peripherally inserted central catheter and increase the risk of an upper extremity deep vein thrombosis. So now they have arm swelling, erythema, and pain. And we get an ultrasound. So what's the treatment for this central catheter that's increased causing the thrombosis? We get 3 months of anticoagulation. You don't necessarily need to take the catheter out. 810, what's the treatment for HIT type 2, where the platelet count is, for example, 40,000? We stop heparin and we start argatroban. We mentioned another one before, Avantapurinax. I mentioned that over here. Okay. HIT increases the risk for arterial thrombosis. That's why patients need to be put on in an alternative form of anticoagulation. 811, a patient has pitting edema and the leg is warm and swollen. What's the next step? So here we're going to ultrasound. Anticoagulation is when, according to the Wells score, there will be a very strong likely diagnosis that there's going to be a pulmonary embolism, such as pleural chest pain, dyspnea, and tachycardia. But since we don't see these signs, just the DVT, we can get the ultrasound. Question 812, a 4-year-old girl develops dark colored urine, elevated bilirubin, and anemia hours after receiving antibiotics, ceftriaxone, and azithromycin. What will reveal the cause? So we mentioned this before. Cephalosporins don't produce G6PD deficiency. They cause the drug-induced hemolytic anemia. That's why I want to look at the COMLEX test. 813, which drug inhibits protein S? We mentioned warfarin wages war on the vitamin K dependent factors, and 2, 3, 9, and 10 CNS. 814, a 66-year-old man has signs of bacterial pneumonia, fever, productive cough, right lower lobe infiltrate, lymphocytosis, splenomegaly, and lymphadenopathy. This sounds like CLL. What's the next step? In CLL, we want to get flow cytometry. We generally don't do biopsy in CLL. Okay. I wrote over here, lymph node biopsy is generally not done for CLL. It's helped for Hodgkin lymphoma or not Hodgkin lymphoma, but not CLL. 815, fine needle aspiration of a subendomedular lymph node in a smoker reals SCC, squamous cell carcinoma. What is needed to treat the primary source? We want to get a laryngopharyngoscopy because it affects the head and neck, the most common locations. 816, a 4-year-old patient's electrophoresis shows hemoglobin A 60%, S 40%, and no hemoglobin F. What's the most common complication of this condition? Hematuria. This is sickle cell trait. They develop hematuria, and there's no treatment for this condition because they are asymptomatic. Okay, take a look at this chart over here where I compare the various. You can take a look at this chart over here where I compare sickle cell trait and sickle cell anemia. 817, a 2-year-old girl has Horner syndrome, ptosis, meiosis, and anhidrosis, and a paravertebral mass. This is concerning for neuroblastoma, as we mentioned before. Patients with neuroblastoma can get Horner syndrome and the paravertebral mass. Question 818, a 6-year-old boy with a history of prolonged bleeding after a tooth extraction has gradually worsening pain, limited range of motion of the right knee, swollen, boggy effusion. This is arthropathy, hemocysteine deposition, and fibrosis. This is excessive because it's hemophilia, and it could develop hemophilic arthropathy, which is hemocysteine deposition and fibrosis. 819, a 7-year-old girl has leg pain, petechiae, and bleeding along the gums. What's the next step we want to get in ascorbic acid level? Because this sounds like scurvy. Question 820, large volume normal saline crystalloids, for example, in a trauma patient. That's what, let's say we were giving that to them. It could lead to all of the above, coagulopathy, hypothermia, and death. That's why we don't give large volume normal saline crystalloids. We want to give, instead, blood products with a ratio of 1 to 1 to 1, red blood cells, plasma, and platelets, similar to what we have in our body. Again, 1 to 1 to 1, red blood cells, plasma, and platelets. Question 821, what should be done in a patient with a DVT with a major GI bleed or intracranial hemorrhage? So they're bleeding and they have DVT. So what do? You can't give a rivaroxaban because they're bleeding. That's going to worsen the bleeding. We have to give an IVC filter in order to prevent a pulmonary embolism. It traps the clot, reducing the risk of pulmonary embolism. 822, why do patients with cystic fibrosis develop bruising and epistaxis? And the answer is because of reduced coagulation factor activation. Remember, vitamin K is required for the coagulation cascade, and patients with cystic fibrosis may not have vitamins A, D, E, and K because of fat malabsorption from pancreatic insufficiency. 823, acute PEs most commonly originate from the thigh, not the calf, from the thigh. 90% from the deep leg veins of the thigh. Question 824, a 60-year-old woman on anticoagulation has acute abdominal pain with a palpable abdominal wall mass. She has anemia and slight leukocytosis. This sounds like a hematoma, a rupture of the inferior epigastric artery leading to a rectus sheath hematoma, and this could be due, for example, to rupture, as we mentioned, from blunt trauma. This could be due to blunt trauma or forceful abdominal contractions. 825, patients with Hodgkin lymphoma are treated are at increased risk for, as we mentioned, solid organ malignancies. Although more than 75% of these patients are cured from the Hodgkin lymphoma, treatment can lead to, after treatment, they can get long-term complications, secondary malignancies, solid organ malignancies, and cardiovascular disease, as we mentioned. All right, that's the end of this video. I hope you enjoyed. Take care.